So back to what I was saying, this was my 9-year-old, and here she was, started to see some symptomatology, and with the help of some brilliant who've become friends, Arun Venkatesan, Joseph Dalmo, we ultimately made the diagnosis of autoimmune encephalitis. And as all of you on the call realize, that it has been quite a journey over the last 3 years. The good news is that she is responding, and I've learned a lot. My wife is also a physician, and we've read about everything you can on this disease. Because I'm a radiologist and a nuclear medicine physician, I possibly took it a step further. My interest now is very much in imaging AE. I have my own imaging centers where I do advanced imaging, including PET. I've been on the medical advisory board of several companies about PET. I still maintain a close relationship with the University of Florida. And in fact, I've been asked to join a task force for a multidisciplinary AE clinic at University of Florida and a pediatric neurology chair. I should also say that years ago, as a student, I was fortunate enough to increase my candidacy to get into medical school, to work in a lab for I guess you could say, a nutty professor. He was a nephrologist and exercise physiologist who had an idea. He was going to make a drink that would make athletes feel better. And we would run around the University of Florida campus. We'd wear plastic gloves. We'd collect sweat. We'd analyze the electrolytes. And that became the formula for the drink. And of course, as some of you know, the University of Florida team is the Gators, and the name of the drink became Gatorade. Now, I don't tell you that to show my relationship with Dr. Cade, except to say that one of the things that Dr. Cade was doing back in the 70s, being a nephrologist, he would dialyze schizophrenics. And as you can imagine, he got in a lot of hot water for doing that. But I did see with my own eyes patients quite psychotic coming into the dialysis unit, and after a few sessions leaving relatively normal. So back then I learned that I have to be a physician, I have to be a scientist, I have to be a dad. And one of the things that I've also learned is that as scientists, we don't create miracle cures as much as we do uncover truths about our bodies and the science and the biology, so that we can improve health. And hopefully this will play a role into what I'm going to talk about today. I want to say also that I am not an expert in AE, but I want to be, not only to help my daughter, but to help others and families and kids and adults that suffer from this disease. And the reason I say that is, if I go back to the year 2000, I had spent about a decade in academics at the University of Florida. I also did my undergrad, grad school, medical school, intern, residency, fellowship, and then became a clinical professor at the University of Florida over a 25-year span. In 2000, I decided to leave academics, go into private practice. At that point, we didn't even have a PET scanner at the University of Florida. We were just about to get one. So I decided to hang out with the folks at the UCLA and befriended Ed Coleman at Duke, and learned a lot about PET. And I was so interested in PET, I wanted to know everything there was to learn about PET. And what I'm going through today reminds me very much of that, because I was really learning about PET, reading all the quintessential articles and getting as much information and talking to the experts that I could to learn about PET. And then lo and behold, by default, I became an expert. And I actually look back at that time in 2000. And since then, 21 years have passed. I've read hundreds of thousands of PET scans. And I can honestly say that back in the year 2000, when people considered me an expert in PET, I was not an expert in PET. To be an expert in PET, you can't look at 100 cases, a few hundred cases. You need to look at thousands of cases, and I'll go through that in this presentation. This is kind of an interesting look at radiologists. I'm a radiologist and a nuclear medicine physician, but one of the things that has become so critically important to me as I try to answer the clinical question that a referring physician would send me is I need to know a lot more about that patient. And as radiologists, we have this technique, the blind radiologist, don't give me any information, let me just read the scan. I think in many ways, it's really short-sighted to do that. One of the things in radiology that's so important is pattern recognition. And Theodore Keats wrote the classic textbook in radiology about all the normal variants. And what that book teaches radiologists is that you really have to understand all the variations of normal before you can call something abnormal. If you look at this picture, immediately they look like sheep. But if you look more carefully, you'll see they're not sheep at all. The patterns can sometimes fool you. And I say that as a caution, again, as we'll talk about in this presentation. In PET, we started out doing whole body scans, mostly in oncology. And one of the things that naturally would happen as you're imaging the head, neck, chest, abdomen, pelvis, and sometimes lower extremities is that you need to understand all the variations of normal before you can call something abnormal. And that's a lot of data, a lot of information, and a lot to know. The same thing happened in MR. I remember back in the early days of MR, we got one of the first scanners in the country at the University of Florida. It was a 0.5 Tesla. We really, I mean, we kind of knew what we were looking at. We all read the articles, but we see these in bright signal intensities, and we call them UBOs, unidentified bright objects, because we really didn't know what caused it. Today, I mean, it's more for research. There's 7 Tesla magnets where you can have just exquisite spatial resolution and detail, but they will also be fraught with the kinds of artifacts that you might see even in a 0.5 or a 1.5 or a 3 Tesla. When I never left radiology, but when I entered the world of nuclear medicine, the thing that I loved, and the reason I got so interested in PET, is that PET looks at things that other imaging modalities don't. Sometimes other modalities do. Perfusion, blood volume, certainly with FDG, the radiotracer that we're going to talk about today, glucose metabolism, oxidative metabolism. It's a visual molecular biology, and we should use that to our advantage. The other thing that's very, very important is that in the early days of PET, you need to make sure that we're doing whatever we can to get these exams covered by Medicare, CMS, so that other insurance companies will cover it, so that the patients can get these scans that they need. I remember back in the day of early PET, 2 things happened, which I learned that you have to essentially work with CMS to make these things happen. The first was with whole body PET for oncology and the staging, restaging, and following response to therapy. And one of the things we saw that early on, CMS was only covering a couple of indications. What we found out is that the reason they weren't covering so many others that needed to be covered is there just wasn't enough data. So essentially, a smart team of nuclear radiologists like myself, not me being smart, but the other ones were smart, we created this idea that if we were to present the data to CMS, that would they come back and cover those indications? So the National Oncologic PET Registry was created. It allowed any Medicare patient to submit, or Medicaid patient to submit the request for authorization, and it would get approved based on us sharing that data with CMS. Same thing happened with Alzheimer's disease and looking at brain imaging with FDG. We actually went to Capitol Hill. It was Dr. Ed Coleman. It was the inventor of the PET scanner, Michael Phelps, some folks from UCLA. We went to Capitol Hill, met with Ted Kennedy, explained the pathophysiology of Alzheimer's disease, the current imaging modalities and other modalities that we have for confirmation of diagnosis, and how PET scans would be very helpful in the full workup for Alzheimer's disease. Well, literally within a few months, Alzheimer's disease was covered for FDG PET, but it required us explaining this to the powers that be to make sure that this is covered. Now, other interesting from the science perspective about PET that you should know is that it's different from the other modalities in so many ways, but one of the essential differences is that where CT and MRI are looking a lot at spatial resolution, we're actually looking at contrast resolution. So it's a hot spot in a cold field. So for example, sometimes a pulmonary doc or an oncologist will ask me, well, how small a lesion can you see? And I'll say, well, I can see a 1 or 2 millimeter lung lesion. And they say, well, that's impossible. It's below the resolution of the PET scanner. And what they're thinking is below the spatial resolution, but it's not below the contrast resolution. In fact, there have been times where I've seen a focal area of FDG accumulation in the lung. I don't see anything on CT. We'll bring the patient back in weeks to months, and there's the pulmonary nodule. So sometimes we see things that's very, very sensitive. We're no longer looking at size, shape, density, or signal intensities that we do on CT, MRI, ultrasound. We're looking at metabolism, and we can quantify that metabolism through all kinds of techniques and software that we have today, but we can even do it visually, which we'll talk about in a little while. When we first started doing PET, and actually Dr. Probasco brought this up today, and that is we didn't image the brain. Basically, we were doing base of skull through the pubic symphysis. I thought that was ridiculous, and all my patients that I do scans on get the brain imaged. And why do we image the brain? Well, first of all, we're already injecting the radiopharmaceutical. Make sure the image the brain first so that you get a good quality image brain with the parameters that we like to use to image the brain, and then do the whole body. The other thing is that I truly believe that often we image the whole bodies too early. So delaying the whole body to get the brain done actually might put the whole body at an advantage as the signal to noise increases over time. The other reason we look at the brain is because we find stuff. It's amazing the amount of times, incidentally, I find things in the brain that had we not imaged the brain, of course, you wouldn't see it. So specifically regarding AE, what we've learned, what the experts have learned, is that AE has, as has been discussed today, a variety of clinical presentations. What we are learning is that AE also has a variety of radiologic presentations. And one of the things we have to be extremely mindful of is that a normal MRI, as Dr. Najjar talked about, is fairly common. In fact, more common than not. So a normal MRI doesn't help us. Does that mean we shouldn't do MRI? Of course we should, but it reminds me of something I said as a first-year resident. We'd be called up to take a case. They put a chest, they want you to look at it and see if you see any abnormalities and give a differential diagnosis. We look at the heart and the mediastinum and the bones and the diaphragms and below the diaphragm, and if you can see the neck, and I wouldn't see any abnormalities. And I would comment, and of course I was a little bit sly when I would say this, I'd say, I'm not calling it normal. I'm just saying I don't see any abnormalities. Now, that doesn't mean the radiologists missed something. It means that the modality may not be sensitive enough to pick up what we're looking for. As far as MRI, while you might see a normal in most cases, we sometimes pick up other things, whether it's infectious, demyelinating, neoplastic, vascular, metabolic. These are the things we look for. And when we find them, they're very helpful. And it doesn't necessarily rule out a concurrent AE, but a lot of times it helps us narrow down our differential. So first, we're going to talk about imaging the brain. And one of the things that I learned as a nuclear radiologist is certainly we can look at things anatomically, CT, MRI. Neurologists, as you know, will look at things electrically. They'll get an EEG. But what we're finding out now is looking at things metabolically is such a complement to those other modalities that it is an essential part of the workup. What we've seen to date, and again, full disclosure, I'm not an expert. I actually haven't even imaged that many brains of patients with AE because we don't get them because in private practice, it's not covered. So no one orders those scans. So I've only seen a handful of cases, but I've read the case reports and the retrospective studies. And as we evaluate the brain, this is what we've learned. We've learned, for example, that in GAD, you'll see hippocampal bright signal. You'll see cortical edema and hypermetabolism. Is that the only thing you'll see? Absolutely not. If you don't see that, is it not GAD? Absolutely not. It's one of the things we can see. Same thing with NMDA. Here's a 27-year-old with tonic-clonic seizures and aphasia, and we see what some consider a classic sign where there's enhancement. With gadolinium, there's bright signal on flare, which is usually the sequence that we use, and there's hypermetabolism. We also see down in the bottom right corner that over time, that injury to the brain caused an encephalomalacia. We can see that on MRI. Also, if in the same patient, we can do things like 3D stereotactic surface projections, and we can age match them to databases, and that can help us and give us a pattern. But does that mean that's the pattern you have to see to make the diagnosis? Absolutely not. Post-treatment, we can see the MRI findings disappear. Sometimes they disappear completely. Sometimes, as was talked about today, we see sequela of the long-term inflammation. We see the pattern on SSP change, but not all the time, not all the same way. paraneoplastic syndrome. This is classic why PET scan is so important. You do a whole body scan. We see a small cell carcinoma in the right hilum. We see the signal abnormality on flare. We see that it goes away post-treatment, and we see the results of that autoimmune encephalitis years later on the PET and the MRI. Again and again, in voltage gate, we see changes on CT, we see changes on MR, we see changes on PET. They are sometimes considered classic, but they're variable. Same thing here with voltage gated, where in the same patient, we see hypermetabolism, we see hypometabolism, we see some areas that have bright signals, some areas have less bright signal. These are what I consider snapshots in time. When we image that patient, that's what it looked like. If you image the patient weeks to months later, years later, you'll see a different pattern. So these snapshots in time are helpful, but I wouldn't hang my hat on them because they do change. It wasn't until Dr. Barbasco, Dr. Salnis, Arun Venkatesan published a paper in 2017 in neurology, neuroimmunology, and neuroinflammation that we started to think about things differently, that this so-called hypermetabolism happens, but that more often we see hypometabolism, and we often see it when the EEG, the MRI, and the CSF is negative. And it was starting to be talked about as a new biomarker. Beautiful images in that. I think Dr. Barbasco showed this earlier today, where they showed the stereotactic projections, the normal MRIs, and how you can visually see it on the axial images. But when you make the 3D stereotactic surface projections, they actually pop out. Dr. Salnis, about the same time, an article was published in the Journal of Nuclear Medicine, pretty much saying the same thing. This article also added that in NMDA, which was a subset of patients in that study, they had all normal MRIs and all abnormal PET. And that's something that we're seeing a lot now. And in fact, I don't want to give it away, but one of the things we're noticing, and we saw it before looking at AE, we saw it at lupus cerebritis, is that the PET scans, I'll say, are almost never normal, where the MRIs are often normal. And then there was a case out of WashU, a paper written out of WashU, where it kind of backtracked a little bit. It said PET CT was equal to MRI, and there was mixed hypo and hypermetabolism. Again, I think now the general consensus, and from everything I've read and from my experience in talking to experts in the field, that you do see a mixed hypo and hypermetabolism. It's predominantly hypometabolism. It depends on when you image the patient, and it's better than MRI, considering that most MRIs are going to be normal. A case out of Spain was a really good case that they said that the metabolic abnormalities, regardless of the method analysis, in other words, you can visually look at it, you can then quantify it, and then you can do these voxel-based statistical service projections. And no matter which way you did it, it was called abnormal. So, one of the things that we learned back in my fellowship days is that if you set your level in Windows, that's what we do in radiology for the non-radiologists watching this, and you set your color scale a certain way, you can visually do and see what computer-generated program can do. What it doesn't do, which is very helpful in these analyses, the statistical parametric mapping, is that now we can compare them to normal databases and abnormal databases. The problem is in pediatrics, we just don't have enough cases to have a database that I believe is sufficient enough where I feel comfortable using that exclusively. And that's what this paper kind of showed. It was a paper that came out of China. It's a brand new paper that I read a couple of weeks ago, that they looked at 3 subgroups: cryptogenic, paraneoplastic, and viral autoimmune encephalitis. And 100% of the patients showed PET CT abnormalities. And what they showed is that the 3D transformation using standard databases and analysis that they were all abnormal. And that's something, if you look at the images on the bottom, you can see how it will really bring out to the non-radiologist the abnormality. And that was, again, confirming what we now know about PET-CT. These were the images that they showed in that very paper about cryptogenic NMDA, where there was no obvious abnormality on MRI, widespread hypermetabolism and hypometabolism at the same time. Paraneoplastic in their study showed a symmetrical bilateral hypermetabolism, including the temporal lobe and the basal ganglia, and diffuse hypometabolism in the parietal occipital lobes. With viral encephalitis, they saw atrophy, they saw subacute hemorrhage, they saw hypometabolism. So again, it's kind of a mixed bag. And I guess what I want to impress upon you is that I wouldn't use an absolute pattern as being pathognomonic, or that you need to see that to include the working diagnosis. And these are the statistical parametric mapping that I just talked about. So what's all the hypo about? Why have we switched from hypermetabolism, which was the initial studies where we talked about there was hypermetabolism on brain PET, to now hypometabolism? And, you know, again, as a non-expert, the way I think about it is the brain is the most energy consuming organ in the body. In fact, one of the reasons, I didn't mention this before, that we weren't imaging the brain early on, if you look at a whole body PET, you'll notice whatever the color scale is, it could be, if it's black and white, the brain is very black. If it's color scale where red is the hottest, the brain is very red. At the end of the day, the brain takes a lot of glucose because it's very energy consuming. But we see this hypometabolism in a host of neurodegenerative disorders. We also see it in seizure disorders, interictal. We also see it in mitochondrial dysfunction. We also see it when patients are treated for seizures and they're on anti-epileptics. I think Dr. Pravasco talked about that today, where you might see a hypometabolism. Patients who are on high-dose steroids that had initial hypermetabolism may go on to have hypometabolism as we bring down the inflammation. One of the theories, and believe me, it is just my theory, I want that disclaimer on there, is that I think of it the way we look at the heart. And in the heart, you'll see ischemia in a patient when you're doing a myocardial perfusion scan. And if you do an FDG PET of that heart, you can determine whether the patient has what's called hibernating myocardium. What hibernating myocardium is that because we're built for survival, before that heart infarcts, it ramps down its metabolism. It becomes hypometabolic to preserve myocardium. I'm wondering, and I'll ask the experts here, is that happening in the brain? As we're trying to preserve brain, are those areas of brain hibernating? Of course, other areas that we need to look at in patients that are working up in AE is the spine. You know, we see the bright signals in the spine that are circled, the so-called H sign on transverse image. And that brings me to an interesting kind of conclusion that I've seen by reading a lot about, not by seeing a lot, of neuromyelitis optica, NMO spectrum disorder. And, you know, we'll typically see the longitudinal extensive transverse myelitis and optic neuritis. The serum IgG, aquaporin 4, reports of MOG that may be another disease happening concurrently, because we know it's associated with other autoimmune diseases. You know, early on, we thought that if there was any brain abnormality, then it was an NMO. We've seen since then that no longer applies. But the heterogeneity of the disease might suggest that there's more going on than we know, maybe multiple antibodies. Certainly things are happening concurrently to cause all these different findings on MRI and PET. And of course, that probably explains some of the heterogeneity that we see in autoimmune disease. Here's an interesting case where you can see abnormal signal in the optic nerve in an NMO case. And of course, just a constellation of abnormal brain findings on various patients. So I like to say is, if AE is the window to our improved understanding of neuropsychiatric disease, as Dr. Najjar talked about, as Dr. as Dr. Pittock talked about, might NMO spectrum disorder serve to better understand the heterogeneity of AE. What I'm going to move to now is to the what I call the not so clinical findings, not so incidental findings, sorry. And one of the things I want to talk about is sinus disease. We often see sinus disease in these patients with autoimmune disease, and there's an ANCA-associated vasculitis that ENT surgeons talk about that has an autoimmune pathophysiology. The reports of sinus disease associated with SLE and sarcoidosis and Sjogren's and rheumatoid arthritis. And because it involves T and B cell regulation, the theory is that with chronic inflammation, exposure of the basal layer, that it triggers an autoimmune response. And so the treatment of sinus disease sometimes is, it works well when you treat the autoimmune disease. And before you treat the autoimmune disease, they can't seem to get the sinus disease under control. And it usually, the sinus disease usually follows the course of the illness. But it's kind of a cat and mouse. One of the things we're seeing is that the sinus disease may have caused, that we see as radiologists, you see the sinus disease on CT scan usually, triggered an autoimmune disease. And then in patients with autoimmune disease, it might trigger a flare. There's a doc who I got to know at the University of Miami who sees autoimmune patients, and he's a true proponent of fix the sinus disease, fix the tonsillitis, and sometimes the autoimmune disease gets better under control. Another thing that's somewhat related is abnormal dentition. A Swedish study looked at the correlation between poor oral health and the incidence of autoimmune disease. Again, it's a vicious cycle where the oral health may have been a trigger, but in a patient with autoimmune disease, it could cause a flare. The question that often comes up, and I can never get an infectious disease doc to tell me the answer, maybe someone on this watching this can say it. Should we pre-medicate AE patients before dental procedures? Other things that we can look at that we see in autoimmune gastrointestinal dysmotility in patients that have AE, gastric emptying studies. Again, am I proposing that we do gastric emptying studies on all patients? No, but if the patient seems like they have a gastroparesis, this may be a confirmatory test. The same thing when patients are constipated and they have poor transit study throughout the bowel. Actually, it was Dr. Pittock back in 2014 started looking at delayed transit time, but few places actually do colonic transit times, but they do improve, as you see here, abnormal transit time. There's all this abnormal activity in the ascending colon. It stays there for a long time. And the patient was treated with IVIG, and you can see it gets through to the distal colon. Liver spleen scans. Again, am I proposing that we do liver spleen scans on patients with AE? No, except I can tell you that there's probably not a more sensitive test to look at early hepatocellular dysfunction. There's a ratio of the amount of sulfur colloid when you inject the patient with sulfur colloid to the liver, spleen, bone marrow, and lung. And when you alter that, it's 85, 10, 4, 1. I used to teach my residents. When you alter that, there is early mild hepatocellular dysfunction. Adrenal insufficiency. Of course, you can have autoimmune disease against the adrenal glands, but how about patients that are on long-term steroids? And you'll see atrophy on CT scan where you barely make out the adrenal glands. It's correlative, but it's not diagnostic. I wouldn't call adrenal insufficiency if I don't see adrenals on a CT, but it's certainly in a patient that has adrenal insufficiency, you might see it on a CT. It might also guide the glucocorticoid and mineralocorticoid therapy. And a lot of these patients with adrenal insufficiencies, you'll see have electrolyte disturbances. Ovarian teratoma, talked about today many times, associated with NMDA. You can sometimes see it with transvaginal ultrasound and MRI, but it's often normal. Or we like to say it's too small to see. PET may be more sensitive, but I can also warn you that there's a lot of false positives. You'll see it in prepubertal women who have their ovaries are starting to change, and we might see uptake in the ovary. We might see it with inflammation. We see it in older patients during the certain phases of the menstrual cycle, inflammatory cysts. Sometimes you'll see inflammatory cyst here, a fallopian tube. Again, a lot of false positives, but when you see it and the patient has NMDA, you have to start thinking about is this the last slide? I think I'm just about done here. Neurogenic versus anatomic. In patients with enuresis or acute urinary retention to rule out an anatomic cause. You may need to put contrast in and look at it to see whether it's the pelvic floor musculature. Is there something anatomic with the bladder or the ureter? Insufficiency fractures. Our patients are on long-term high-dose steroids. And insufficiency fractures, some people call it a subclass of stress fractures. I actually don't. It's actually somewhat the opposite of a stress fracture. A stress fracture is abnormal stress on normal bone. This is normal stress on abnormal bone. And we see it from osteoporotic insufficiency fractures and vitamin D deficiencies. It's another advantage of whole body PET because we'll see those. So we must be careful not to separate the brain from the rest of the body. There are a lot of other things we can image that can help us because there's a lot of other pathologies that are present. It gives us a better look. And probably the one other take home I want to give you today, it's not about the race car. I mean, you could have the best PET CT scanner, nuclear medicines, gamma camera, MRI. You need to have a radiologist that has seen a lot of these cases, maybe hundreds of thousands of cases, to be able to help you make these diagnoses. Again, it's not about the race car, it's about the race car driver. And the conversion of this multimodality, multi-specialty approach is so important. They used to call it fusion or the F word because it actually makes us think. We start thinking of anatomic, metabolically, electrically, things that are going on in the brain that can help us make the diagnosis. But the future, the more we learn, the more we see, the more questions we ask. PET, for example, we learned early on, not an AE, but it can be a prognosticator. This is radio-labeled oxygen in a patient with middle cerebral artery ischemia. So what happens in the brain is that you inject the patient with radio-labeled oxygen. They're extracting as much oxygen as they can, more than normal brain, to survive. And we see the area that's green and yellow here as not that the patient's infarcted, but this patient is at extremely high risk of infarcting. So there may be future radioligands that we look at that can help predict treatment response. We see bradykinesia, slowness in movement, failure of the basal ganglia. We have radiopharmaceuticals that can actually image the basal ganglia. Nobody's doing it now, and especially not doing it in kids, but we do it all the time in Parkinson's disease. Dritten Aguilar, for those who know him from Columbia, he's an expert on the blood-brain barrier. And there have been studies in rats that have looked at the disruption of the blood-brain barrier and the extravasation of albumin and gliosis that takes place. And there are radio tracers that can actually see this. Again, there's not a lot of work being done. I texted Dritten the other day and asked him, is anyone doing this in MRI or PET? We don't know of any, but this is an area that we should be looking at down the road because we know that the blood-brain barrier is so important in this pathophysiology. Visual snow. Some of your patients may describe that the way they see sometimes looks like static on a TV, involves the thalamus and the posterior parietal, occipital, and prefrontal lobe dysfunction and discoordination. It's too small to see on an MR, probably, but might we be able to see it with certain radiopharmaceuticals? Again, we're imaging snapshots in time. Dynamic imaging is of critical importance. Do we image too early? Like I mentioned, sometimes if we image later, we increase the signal to noise. Sometimes do we see a patient, their MRIs and PETs are normal, but what we're seeing is down the road, they become abnormal. Dynamic imaging is important. We used to use it in a lot of lung nodules in particular, where we'd image a lung nodule on the first pass through the patient, and then we'd bring the patient back 30 minutes, 45, an hour later, and look at the metabolic activity in that nodule over time that helped us decide whether this was an inflammatory or a malignant nodule. I think we can do the same kind of dynamic imaging in the brain that will give us a lot of information. No one is doing it that I know of. We need to look at this and see if we can collect data and see if dynamic imaging can help us make the diagnosis. One of the things that I noticed when my daughter was getting plasmapheresis is whatever we're removing, it's in that bag. Does anyone look at the bag? Is there a way to see what we're filtering, or is everything being filtered and it's not helpful? But what I do know is whatever we're filtering after a patient responds well to plasmapheresis, it's in that bag. Radio tracers in the future may be tagged to known biochemistry that we see with AE that can serve as a virtual biopsy. We're not there yet, but it seems like that's the future. Following treatment response. We do it all the time in oncology. Remember, PET started out more as an oncology modality. We sometimes see no change. We see improvements. Sometimes they go back to normal. Sometimes we see residual findings. It's heterogeneous in its appearance, pre and post, but following response to therapy is very important. So in closing, what I'd like to say is in cases, especially when the serum, CSF, EEG, and MRI are negative, PET may wind up being the most helpful biomarker. Like baseball player Cal Ripken once said, which I thought was brilliant, practice doesn't make perfect. Perfect practice makes perfect. We're getting there, but we're not there yet. I'd like to have Anya, my daughter, get back to where we were and enjoying life, and I think we will, with the help of some of the brilliant folks here in this talk today. And again, I end by saying, the more we learn, the more we need to learn. Thank you very much for having me speak today.